No, it's real.
Okay. Oh my God.
Audio and visual.
I mean,
And we have the mayor.
this is the thing that I'm wondering is like, we've done this so many times, and will we ever figure it out? No, we will not. Again, I'd like to remind our loyal fans this is a extreme budget operation. And we also don't have our amazing community manager, Melissa, with us.
Melissa's at home.
Also tech support, also everything else, fixer, all of the above. She's not here.
She's not here. She's at home. That's really sad because but Melissa, we did mostly figure this out. We actually aren't sure if are the
We
little
don't
lights
know. Yeah, the lights on.
Lights are on.
All right.
Okay, so we're in
We're
Amsterdam.
Tash.
We're in Amsterdam today.
The same
We've
people.
been in Amsterdam for a while. It does seem like there are all the same people. We always go to conferences here. They're all here. Here, it's the same crowd. We met some new friends.
Yeah,
we met some new friends. We touched last night.
Yes.
We met that Galen,
Julian, Sarah.
Yeah, it was
It's pretty good.
Are we too loud? Okay. All right, you just tell us if we are.
Amy's gonna give us the hook.
Anyway, it is. We're in Amsterdam.
This is total chaos. Yes, it is amazing.
Pacific time.
It's different.
Yeah, it doesn't matter. Anyway, here's the thing. So we're in Health Europe. It's the first Health Europe.
Yeah.
It's yes, it is the first one. So far so good. So far nothing terrible has happened to us.
No, I mean we made it.
No, and stayed awake through some.
I was awake. I mean,
Lisa was.
I was so mentally asleep, but I was physically there. There were things that were.
Yeah. You were taking, you know, it was being taken in. I think, right?
Yeah. No, I was embarrassing Kat, which is my job.
Oh my God, I was so embarrassed.
Yeah. I don't know if it was embarrassing. I would say maybe just a little. Okay.
It's much. No, so here's the thing. So this is day. So yesterday was day zero of Health Europe, and we were totally here. Lisa came off the plane. We went to Ritesh's panel with Galen Growth people.
Yeah.
It was rad. They did all kinds of stats and basically said that all investment in the U.S. stays in the U.S. for healthcare. And basically everyone else's investment also stays in the U.S. is what we learned. Yeah.
It was just kind of sad. And you know, my like grand economic theory about this is that the U.S. has an unlimited money printing machine, and that's why, of course, anyone investing in health tech is like, great, we'll go there. It's going to be amazing. Yeah.
But it's funny because the Europeans that I sort of met afterwards, a lot of them were saying what was interesting was they didn't realize that the U.S. is actually different. That they have to figure out a business model for getting to the U.S. They were very surprised at that. They were like, wait, we actually have to figure out how to pay for this?
Yeah.
You know, so I guess the single payer model here doesn't, you know, yeah, exactly.
Well, anyway, hey, we didn't even introduce you, Ritesh. So you need to tell us who you are, why you're the mayor. Basically everywhere I've been in Europe.
I don't know if you were the one who started calling me the mayor.
Yeah.
You know, I wasn't the one who did that. But hi, everyone. Ritesh Patel. I work at Fin Partners in New York, run the digital health practice. And I don't know how we met, but, you know, I've been hanging out with these two since.
Yeah, I don't actually know how we met either.
I have no idea. So it's all blurred together. There you go.
Say certain things, you know, some people, we like to pretend we do things too. So.
And apparently I'm the mayor because I seem to know everyone.
Yeah,
you know,
everybody seems to like run the deep state conference panel scheme. So that's we're into that.
Yeah.
Also, thank you to Michael Marchant, who did send us 3 mics. It turns out we can only figure out how to sync 2 at a time. So we're back where we usually are, which is right here.
More tech support than that.
This is right here.
Although your efforts were great.
Yeah, we very much appreciate it.
We didn't do the turn it off and turn it on thing at least twice.
We did.
Yeah, we tried that.
Oh, wait.
Uh-oh.
And we're not live. Oh.
Okay, look at that.
This
is brilliant.
This is always what's going on.
Exactly. Maybe, you know what? I'm going to have to become tech support for you guys. Right?
Well, yeah,
usually I have to do that. Yeah. October. Nothing's moved on a little bit. The interesting things were the government. I went to 2 government panels, one for the UK on how to access the UK, and how to become a provider in the NHS, right? So that was interesting because they actually showed and talked about, this is what you need to do if you want to work with the NHS. So for those startups that were in that room, that was quite good. But otherwise, with hearing the themes are ambience going to be everywhere. Soon you're going to be talking to your computer just like they do on Star Trek. And I'm sitting there going, okay, I'm in a hospital in West Virginia. Am I really going to talk to the? Yeah, exactly.
There's always like a huge disparity. We can talk about any tech between these urban hospitals and like the not urban hospitals. I think the ambient voice recognition scribing stuff is like legit. Like I think that'll
Yeah, Nuance has done an amazing job for Microsoft. They've done an amazing job.
Nuance hasn't been an overnight success.
No.
They have now.
Did they buy Dragon or something?
This has been extensive work. It's not enough to just say, oh, I turned the AI on and I said generate and like listen and generate what you think that might have been. Like that's not what they do. They have a lot of experience.
So what was interesting was Harpreet yesterday, Sud. Remember? Because he was good, right?
Yeah,
I mean, he's a doctor. Yeah.
He had some like government job.
Yeah.
He was like a legit dude.
He was. And it was fascinating to hear him talk about, I've got 22 doctors and I'm the only one using Ambient because the others just don't want to, right?
Scary though about that panel though with I think it was Sunil.
Sunil from Atlantic.
He was saying things that kind of freaked me out, like also that they're so advanced. But he was like, "Oh yeah," and then it generates the note, and then it provides a recommended script back to the patient, and the doctor can review it. And I was like, "Oh, wow."
Will the doctor review it? Will the doctor review it?
Yeah,
because that's the thing, right? I really do worry that we may become lazy.
Yeah, well, that's the thing, and it's
right,
like,
and not
it's not maybe.
okay.
Whether they have the best intentions or not, they have it's what's called like automation bias.
Yeah.
You think that if the machine tells you something that it's fake. And I mean, it's not that people are lazy or not. It's that's how our brains are wired.
Yeah.
We're kind of fancy apes, right? We're fancied up.
I mean, it's not too different to checking your Excel spreadsheet, right? I still check the cells, even though somebody said, look, if the total's right, I still do it in my head just to make sure, because you never know, bad formula, miss a cell.
Right.
You got 100.
And like, I don't want to say like doctors are lazy, right? Like they're also
they're
burnt
human
out.
beings.
They're burnt out. They're human beings, and like the point of a lot of tech in the U.S. is, as described yesterday, is to do more faster, to build more things,
more widgets,
and
more healthier widgets.
People get burned out, and if they see a thing, and the thing said to do the thing, and so that did scare me a little bit, but they seemed pretty legit too. I was pretty stressed.
They were good. Sunil was good. I think, overall, what I'm seeing here, you've got the big tech guys. Google Health has got a massive presence. Amazon's got a massive presence here. Microsoft's got a massive presence here. And then you got all these little companies. I just went to about 7 of them just now. And they're all doing little things like data and interoperability and data and more data and security and data. All right, where are we in the patients? What are we doing with patients?
Well, we are going to meet a patient advocate in a moment, Valerie, who's here. But who also works. Yep, she's right there. She also works at a health tech company, but she's going to tell us a little bit about that. They do have an Ask Patients booth here again, like they've done at Health and Vive, which is great.
Oh yeah, Jen Hornjeff is here.
Exactly. Yeah, so you're doing some of that stuff, but like I'm interested in hearing what is different and the same between the patient advocacy and patient involvement here versus in the US or elsewhere. But I mean, yeah, this is, and then also, by the way, like all of, Microsoft and Amazon and all those things, like you said, there's the behemoths compared to the tiny little, compared to the US undercapitalized startups. LOL.
I ran into a guy as I was walking into my hotel room last night. Got off the same floor. We started talking 11 at night in the hallway. He's a seed capital guy here. Yeah, and he's here to meet other, potential startups because he's got $100 million seed capital fund. Only seed and early stage. Okay, good.
That's fine. Because the first few minutes are always real. soon.
Anyway, keep going, keep going.
Oh, no.
Yeah,
$100 million seed, a seed to, yeah, it's a lot of money here. And I said, so where are you deploying? And he said, no, I'm here to meet people to deploy.
Like to give some people my money.
Exactly. I said, that's very cool. And then get a guy in, door opens, the guy who offers him goes, could you guys go have a conversation somewhere? Sleep.
He's like, we're trying to give $100 million.
Yeah, exactly. So there is some pockets of money here. There is pockets of money here, and there are people willing to do it. But I think the problem is, it's fascinating. I met with the guy who runs innovation at Pfizer for patients. And, he's here wandering the hallways, talking to people. They've launched an app in partnership with other companies, which is amazing for a pharma company. And he said, everybody I talked to, they said, well, you can't do that here. We can't promote drugs to patients directly. So it's like, oh, okay, so my market is just the US. Thank you for confirming that.
Well, New Zealand also.
Oh, yeah, that's good.
Well, New Zealand is the only other country that allows the same level of direct-to-patient advertising by pharmaceuticals. It is a much smaller market, though.
I don't know. It's compared to the US, yeah. So.
Expand to New Zealand. Sorry, love you, New Zealand, or whatever. Whatever.
Yeah.
So, like, what do you think? Like, okay, what's your prediction for like what's going to be the big thing coming out of Health this week, Health Europe, and like, what do you think Health Europe is going to be?
Philips has a big announcement today.
Apparently, Philips has a big
They invited us.
You were invited. Oh, wow.
Invited.
Amazing. Look at you two. I'm hanging out with celebrities. They call me the mayor, and the rock stars have been invited to all these private events,
Again, the barrier to entry love you a little bit low because we are obviously rodeo clowns, but
Yeah, I feel like it's fine.
Yeah, but so all I've seen so far is, everybody's focused on AI.
Yeah.
AI seems to be the big thing. And the conversation earlier, it was all silver bullet stuff. It's going to fix this and fix that. And I'm like, guys, really? You're playing at the hype, but it's exactly what it is.
I mean, it's a little combative because Lisa was in it. Your panel. I said ours. I feel like we shared it.
You did.
But not even the most person asking the most questions.
Oh, they're like,
That's true. You said it's going to be
Exactly.
That's
interactive.
How was the panel? Because you went to one earlier.
I've been to two so far.
The interactive here, people are throwing things.
The other bit, disappointingly, they're all manuals still,
That's so interesting.
which is very fascinating.
The no man.
Yeah.
In the US, there's a you can be a man here.
Yes, no.
You can be a man if you are a man.
Come to Health Europe. Yes.
There are plenty of women here, and in fact, we have plenty of women on. Excuse me, as I just same thing. Talking about health equity.
It's the only ones that I've been to. So I'm sure there are. Well, it's just, yes, it's the unconscious bias, I suppose.
What's health going to be?
So they've got a 4 or 5 year plan, apparently, allegedly. I think it's not. I think it stays this. I don't think it's going to get any bigger because the markets aren't bigger compared to the US. So I don't think it'll ever be the scale of the US Las Vegas thing because that is just
and plenty of European investors and tech startups.
Exactly.
People showed up here.
Yeah,
Probably.
Exactly. I think it'll be the same size next year. I don't think it'll be any bigger. The quality of some of the panels is good though. There's some good heavy hitting sort of C types here, like they do in the US. My only thing always is, who are the people who are actually doing stuff, and can they share the actual knowledge of the things, like we tried to do on the panel yesterday, right?
Yeah.
Well, exactly how did you do that, and what happened? A lot of that doesn't get in the panel, right? It's all around the showcase and the show. So it's fine, fine.
There's another venue as well. On Thursday, I think there's a Middle East North Africa forum here.
Yes.
Usually a shorter trip for people who live in Middle East North Africa. So I think there's going to continue to be more of a presence here, and they can build that out. I know there are some conferences, obviously, in the Middle East who are doing this kind of work, but I think this will be maybe a beacon for some of that work.
I hope so, because this is all digital, right? So if you look at the Middle East, Africa, there's so much there, but most of the investment is going into physical. They're building hospitals, they're building medical cities. They're not, if I were
Like global US.
exactly. Robert Wood Johnson is doing something, Mayo's doing something, right? So my view is, hey, you should build an accelerator innovator hub.
Yeah.
Right? Dubai or Saudi or Qatar even, they've got the money. Put an accelerator in there, put an innovation hub there.
Yeah.
We've got nothing.
Nope. Wow.
On Thursday,
facing the Israeli area, which is in the US too.
Yes.
Yeah, and they have like a huge accelerators.
Yep. Well, Sheba Medical's got a huge accelerator. Chicago Arc and all those things.
Well, realities may be affecting.
Well, yeah.
Here. Political, practical realities maybe.
I mean, the big things for you guys, I'm not sure. For me, it is different to actually see Europeans and other countries here. I met somebody from Romania yesterday. I met somebody from Slovenia yesterday who's here. That's really interesting. That's pretty cool. Yeah.
I mean, all of the things are
here. Let's get some guests. Thank you. Oh no, my pleasure. My pleasure. Yes, sir.
Yeah. All right. Valerie. We got a new guest coming on in just a moment.
maybe
Ben and then Valerie. Real time switch because we haven't actually planned any of this.
Ben is very important, you all. We have Dr. Ben Zaniello, CMO of Best Buy Health. Again, repeat guest.
Fellow Italian.
He was on the show.
Bari and Zaniello.
We are.
Barese.
Yes. I will continue being an American.
Are you not going to go with your maiden name?
Kowalczyk.
Yes. Here I am.
I mean, some of us
speak some adorably bad Dutch. Like,
Aww.
yeah, I can. It's like,
but not Polish.
I can speak a little bit Welsh.
It depends on the situation, where we are in the world.
Right. Yeah. We can do things here and there, like how do I get a cup of coffee?
That's right.
Yeah.
Yes.
You are here.
Yeah.
We are here together.
Yeah.
You're speaking at a panel later this week.
Probably should remind everyone what Ben's job is.
Oh, I just said he's the CMO of Best Buy Health,
Right.
the Chief Marketing Officer.
He is not the Chief Marketing Officer.
Right. I can only dare to dream to be the chief. We could have done this.
It is a very glamorous job. You have the other CMOs telling you you're out of your job.
I'm used to that. The CMO at Best Buy is very nice. Maybe nicer than my former
I don't know.
marketing officer.
We had a great
Just
report.
saying.
Just
saying.
We had a great report.
Yes.
In case no one knows the great history, Ben and I worked together at Collective Medical. We were both CMOs, though he was actually the higher paid one.
Pat doesn't know that for a fact, but
Yes, I do.
probably safe to assume.
It's not illegal to discuss your salaries, everyone.
My doctorate is from the School of Hard Knocks, and
That's
yours
right.
wasn't. So anyway,
So Europe.
Health Europe.
Okay, so yeah,
You're
like,
here.
what is even the deal? So Best Buy Health, like, bought a European company. Like, what? Why are you here?
The biggest exits for a
So it was top
European
right?
startup. From my understanding, the former CEO has said multiple times it's either one or two, depending on how you frame
One.
it.
I would always
Yes, right.
Yeah.
It's current.
So current.
Current Health, which is a Scottish Edinburgh-based RPM hospital at home company.
Yeah.
Because that's core to what Best Buy does in healthcare, which is care at home. So I was actually just at the Health Europe Care at Home session.
How was it? I actually, because you texted me. So are you
Right.
going to, what I would like to know is what you're going to say to our audience.
Right. I think it's hard right now for this show in its first year to kind of stick the landing. I think it's a little bit finding itself is my how I would frame it. I think
Hey, conferences are really hard. Like, to be clear, like,
yes,
it is extremely hard to pull off a big conference like this. Jesus, I mean,
yeah, no, I think one of the issues, and actually it was kind of the second half of the panel got kind of interesting, and the guy from HUMA, HUMA, basically said that if you're working in healthcare, digital health tech, if you're not working in the United States, then good luck. Yeah. And the framing, of course, was just about reimbursement and money. He said, you know, a important a trial or pilot of your system in the U.S., you know, could bring in, you know, 2 million people. And he's like, there you've hit half the population of the Netherlands. Wow. So I don't know if that's valid or not. I don't know. That doesn't sound right to me. But anyway, and I'm probably misquoting. To be clear, I'm probably misquoting him.
But there's more than 4 million people. That could be
right. Yeah.
We're not going to Google it. We're just going to be ourselves.
Right.
Yes.
Yeah. So to the point, I think it's a
like that would be a weird change.
Right. Yes. I think the framing that it is, it's a little bit hard to talk about healthcare in generalities, particularly when in the U.S. based system, everything is reimbursement and finance based, and here the models are very different. So I actually think while there are opportunities to learn, quote, from one another and to look for software, digital health that can transcend, and vice versa, U.S. companies that can operate here, I almost think that should be more explicit. Like we are,
a thesis, like a theory
yes,
change,
like more like, like this is comparative healthcare, right? Like we should be talking explicitly around that versus like, let's have a women's health panel and talk about 4 women's health apps that may or may not see
on period tracking.
Right.
I mean, I want to say that if you were a U.S. investor, that you could get a discount on great technology and a great team, except for product development doesn't work like that, right? If you build a product, then you try and staple on reimbursement.
Yeah.
It's going to work.
That's exactly. I mean, it takes.
You can probably find some great people and great teams and great ideas, but that how you make money out of it, how it works, how the actual remuneration works, those things are core to how products actually built in this vision.
Totally well said. And I'm sure there are people smarter than me and have the insight of being able to map those products here to U.S. healthcare issues. But I think that's hard. So that I'm a little bit kind of figuring that out. Like, what can I get out of this show? What's the best way to do it? However, I did have a lovely group waffle on my way.
I mean, we've been having a great time overall. Let's be clear. We've been having a great time. Having a lovely time. We had a lovely dinner. We lost you with your man.
Yes.
We don't know where that guy went, but we've been having a lovely time. But you know what? There are startups that I'd say how many of our
amazing ideas,
dumb startups fail in the U.S. because of the same problem.
Yeah.
Like, there's a different way to make money.
They don't think about what that looks like.
Yeah. 80% of
them are so far then, but Pharma is, of course, genius at figuring out reimbursement in a ton of different countries, different systems. But they have to think about it too, right?
And
they market products. They do product and product marketing differently per country because of reimbursement.
Well, and I guess I'm looking for kind of the explicit, like, just as I think we've gotten good at these conferences in the U.S. It's saying, we're going to talk about health plans now. We're going to focus on reimbursement. How can you map the reimbursement? Like, I would probably have a little more like, how does pharma operate? This is how we're going to, how pharma can look at companies, et cetera. Yeah. So it's just, I mean, again, it's approach. It's first year, really kind of hard to figure out what is the what.
If they're sure that they're going to move around to different cities. I assume they are.
They have a plan. I don't know.
You guys look at me as if I am knowledgeable.
You are.
They would. I mean, Amsterdam's pretty rocking.
I mean, I would be all right.
Pretty central.
It is. Yeah.
Delta Kale.
And it's helpful that, as far as I can tell, the entire city speaks better English than I do.
Yep.
So
the level of English is truly in this world.
Yeah.
Thanks to the Dutch.
Yes.
Thank you.
Yeah.
Ben, like, what do you think your big thing? What are you going to walk away with this conference? If you like, OMG, like, what would be like a total win?
that's
you know, you just
interesting.
told me you have to be somewhere at 10:30.
Uh,
Get in the hook.
I mean, I've certainly talked to some interesting people and learned kind of interesting things that they are doing in spaces. It doesn't necessarily map to anything that I'm particularly focused on. So
You
it's
just
more kind
heard
of
something
global
home
or
care, something that
yeah,
seemed like
yeah, right, right.
have a discussion
Yeah.
with.
But again, back to I went to this care at home piece. And I think it was really hard for the 5 people on stage to find like a shared understanding that people could walk away from without resorting to kind of fairly high level statements that patients are also consumers and patients are consumers at home and they like to have choice in healthcare. And I think we're all very kind of comfortable with that thought if we're at a healthcare conference. I would like to think that. But,
Maybe something in a localization layer. I mean, that would be a lot of deep product work with companies, but maybe there is something to be. Maybe there is some appetite for working in an accelerator like format with European or Middle East, North Africa, or Asia Pacific startups too. I'm sure that probably this exists, and everyone who's watching, all 0 to 1 people are like, that's yeah. I mean, I just maybe there's something to be like a more systematic way of localizing to the U.S. market.
well, and theoretically, how we do kind of innovation and looking at a model of care, you would actually say in this environment where reimbursement is less of a focus, you can actually prove out the ROI. Right. You can show that this is a better quality, and then say, okay, we know that this works, so then let's figure out the reimbursement for it. Because I feel there's like that chicken and egg issue of we believe we can save money doing this, but we're not even sure that it is actually more effective at care. So you're a little bit stuck, particularly with the health plans.
So we show.
Yeah,
we can make money with this, and also it actually meaningfully works, and it works.
Yeah.
It's always the challenge, and then as everyone knows, we're no longer in cheap money land, and so the willingness to sit it out and figure out that oh well, does it actually can we actually pay for this versus having the time to prove out that we can actually make health outcomes better is things are in conflict with each other. Money isn't cheap anymore.
And I also add as a takeaway that you can actually, if you're conscious about it, avoid AI sessions. You can look at the thing and say,
he's like, there's no way.
you can you look at it and say, they're definitely going to talk about AI here. So I'm going to avoid this session, and therefore I won't hear any more about the solution in search of a problem.
I think exactly. And I think what it is for me is like, I am not hearing anything new beyond, as Ritesh put it, silver bullet ideas that have no basis in reality. And like very cool, a huge, massive, really fast, really expensive large language model is not going to solve the vast majority of our problems in healthcare. Will the application of action-based things, smaller and specially trained and traceable, maybe in the future? No, nothing new.
I'm not going to diagnose shit.
No. Well, I mean, I think there's plenty of new stuff. It's applicability and
just being rehashed again. And as a kind of like, I have to say this, and like, well, AI and machine learning and it's like, what are you saying?
Well, and I actually think this is an awesome one for healthcare to be a fast follower in an early because of the just patient risk and care and the equity issue, right? Because the whole point of doing this with big data sets is that you can get really precise and with your healthcare choices, but if you're building it off crappy models based on a limited set of people, genders, etc. See, now I'm talking about it.
There you go. Damn it. So you got to go.
Yes. And you're going to have Valerie on, who's absolutely
she's amazing.
Is she a better guest than you?
Yes.
Thank you, Ben. Valerie.
Ben, you're the best. See you later.
Yes, you're always on.
We never tune out.
Yes.
There's a
Text
McDermott
back.
party. Byron, no, I am on a live TV show right now. We'll figure this out later. Here you go. Thank you.
Don't be pressing on me.
First real guest, Valerie Storms.
Really excited to talk to.
Valerie.
So Valerie, oh my gosh, patient advocate, also a real like executive,
Real health tech executive.
Like, a real thing. Tell us all, like, just introduce yourselves to our loyal fans. Yeah,
All zero to one.
We're definitely still sleeping. We'll watch this later.
Okay. So maybe like just to open in a spectacular way is that I wasn't sitting here today if it wasn't for the revolution in medical technology and science, because I'm a cystic fibrosis patient. And I was just talking to your previous two guests who are both really like aware on CF. And I think also in US, you have like an amazing patient advocacy and patient community for CF. And I was one of those lucky patients that 10 years ago could enter clinical trial with the new drug. And that's my life changed like 180 degrees. And that's why I'm here today at this Congress. And that's why I could start working in digital tech. And the reason why I choose for that domain is because before this huge new drug that came to the market, the quality of life of patients was mainly impacted by social media, by digital technology, because many cystic fibrosis patients also have or suffer from diabetes, diabetes type 1. And another major impact was this digital technology and sensor technology for diabetes that came on the market, CGM, that really helped to manage the disease, to be in control, to have data and insights. And so I became this patient advocate for digital and data, and make sure that patients have the data, that they are empowered, and that they're also less dependent on the patient-physician relationship. Because to be honest, it's not always as positive as everyone thinks. Like sometimes your relation isn't optimal, and then what you do as patients. So that's my voice that I want to bring to the table, that we need to empower patients. We need to give them the data, help them to understand, so that they are really more like have the power to influence their own healthcare.
And then you have also a job, a real full-time job as well.
Yes.
An unpaid job probably, and then a real
paid job. Many of our patient advocates,
they have many
just
jobs
starting to get paid, but most of them are the hardest working, lowest paid.
Yes, indeed. It's really hard to make a job from it. So everything I do as patient advocate is voluntarily. So like even here today, I was asked to sit in a panel debate this afternoon. But then they say like, no, we don't pay speakers. So you only get the free tickets, but who's paying the hotel? Who's paying your travel? So it's really tough for patient advocates, because we're always like, where are the patient advocates at these kind of meetings? Yeah, it's hard for them because everyone here is paid by the company to travel. Hotel is paid by the company. It's such a different situation. Something we need to think on how we can change that.
I mean, I think it's really important to make sure that people can attend who can speak from their actual experience, living with a disease, living, as a patient with physicians or digital health. And I think that those things should be covered, and nobody should be asked to work for free. Because it's work.
It's true.
It's important. So tell us about the actual company, like your paid job.
My paid job. Interesting as well. So I work for a pharma company, Daiichi Sankyo, also located in US. I'm working for the European hub. It's a Japanese company, so our headquarters are in Japan, or in Tokyo. And I'm responsible for the digital health transformation of the company for 7 European markets. And the idea is that we really try to look at healthcare as a service. It's like this new way of saying that you don't only provide pills to patients, but that you try to bring also services related to your drugs. So, for example, therapy adherence solutions, disease management, apps to support patients, but also for physicians. How can we better support physicians in making the right therapy choices for patients based on, for example, better data or access to data? So it's kind of broad. and we focus mainly on cardiology is the main area, and we hope to also enter oncology soon. So two disease areas. Yeah.
Is that your background that you have always been in?
I have a more like an engineering background and university background. Yeah. And that's why like patient advocacy is super from the heart. But I also wanted to do something with my engineering background and with digital technology.
Yeah.
I kind of can combine both because it's for patients, but still like the technology part is super interesting as well too.
Yeah.
And everything that is going on like with AI and ChatGPT, like it's so exciting to live. I think today in this era to see all these kind of tech like super rising and exponentially growing. So yeah, it's a very interesting field to be in.
Very cool.
But you guys are also in the health tech.
We are. We have real jobs that we do this side. This does not pay us.
It's also voluntarily.
This
is that's it. Like my patient advocacy is also the most fun. So that's
yeah. So what have you seen so far of Health Europe? What are you hoping to see here? You already mentioned that it's certainly not great that patients are being asked to serve on panels and not being compensated for that or being brought here as a patient advocate. What else are you? What are you hoping to see? What have you seen so far?
So far, not that much.
The start. This day
exception to connect with some people. I'm really interested in the whole AI part, so I select all the talks where AI is
going to the AI talks that we're not going to. Tell us, you're going to go to them.
I'm going to them, yes, just to get a better understanding how we can concretely, tangibly use it, because it's like this big buzzword everyone is using, and I'm really looking for the use cases, the tangible experiences from hospitals. I hope to hear some of that today. And then I have this panel debate on social media and the impact of social media this afternoon.
Tell us about that.
Yeah, we are going to talk about misinformation on the internet, and how we can combat that. Also, the fact that there is like a lack of credible, safe information because physicians are like underrepresented at these social media. It's often like patient peers among each other. And for example, what I noticed in my Facebook groups of cystic fibrosis is that patients start to ask questions to each other because they feel they can't ask it to their physicians. They are sometimes afraid to ask the questions that really concern them, or they feel misunderstood by the physician. So then they go to the Facebook group. And then you feel like, oh, I'm gaining weight due to the drug. What do you do? Or I have a lot of rash. What do you do? And then people start giving advice like, oh, I reduced my drug dosage. I only take the morning dose and not the evening dose. And then you see that patients are doing self-medication. They're like, oh, I will try that as well. Yeah. And so that's a bit the negative aspect of it, that people are just relying on advice from other patients and taking it for the truth or trying it out. Which could be good though. The type 1 diabetes patients in the U.S. with the glucose monitor or I think it's the glucose pump.
The full.
Like actually,
and they hacked into. I think it did get approved. Obviously, don't fact check us, everyone. But there was a real patient-led movement to hack into the CGM.
It was
to get the data. Right.
Indeed.
And then I think they finally did approve that, but it was a big issue.
What happened if those communities weren't talking? And
I'm sure you're not.
Really bad things can happen. Bad things can happen.
Yeah. It has positives and it has negatives, and it was more like, okay, what can we do to that the positive outweigh the negatives? I think, but I'm truly for patient communities, because I was talking to the previous guest. What was his name?
Ritesh and then Ben.
Yeah, Pritesh. And he said that he was like 10 years ago, he made the first cystic fibrosis patient community in the US. So
there's not anything he hasn't done. It ranges from running an incredibly successful. He's done it.
Yeah, I know digital stuff.
Yeah.
That's so
Not so
interesting.
That was really interesting, and it was really meant for mothers, young mothers that get a baby with diagnosed with CF, that they could connect to other mothers who are like already like grown-up children or other CF patients to kind of reassure them, because it was a very heavy diagnosis. And in that way, social media was super powerful, because I don't know if you know, guys, but CF is kind of, you can't meet in person because you can contaminate each other.
I know this only because of John Green's book, The
Okay.
Fault in Our Stars.
Okay, yeah.
It's,
Yeah,
and the
I'll say
movie.
I'm a cystic fibrosis carrier.
Okay.
Thankfully, my husband is not.
Yeah, you are aware of it, because many people are, but
Yeah,
they don't know it.
I was tested.
You got tested,
It was like a trial thing that I had no reason to be, and my doctor tested me, and then it was like this whole thing, and
Wow.
everybody was freaking out, but it all.
But yeah, so
ended up okay.
online community, incredibly important.
Yeah, I know it was on my
Yeah.
page. So I was like, what do I do if this is the case, you know?
Right.
Yeah.
But there was an amazing article, because I don't think a lot of people know the big advances in care for cystic fibrosis patients. So there was an amazing article in the Atlantic
Yeah.
a couple of months ago detailing the new drug and how it doesn't work for anybody.
I need to check.
A lot of people. Yeah, and like life changing.
Yeah,
so it's
totally
amazing.
life changing.
I mean, like you're saying, you're
Yeah, like
Yeah,
so many people can breathe. Like they can breathe.
Oh my god.
Something
Something
already.
it's incredible.
It's really incredible.
It's really amazing. Yeah, I mean, for all the negativity that I sometimes feel about healthcare and health tech, there have been truly life-changing advancements, and it's this being one of them, CF being one of them, right?
Are you aware of tech in CF? I'm not. I don't see a lot happening there. Like for my diabetes, there is a lot, and there are
lot of diabetes tech.
But CF is like less present in the tech, so I hope we can change it in the future to have better disease follow-up.
It's a rare disease. It doesn't seem rare, super rare, because there actually has been, probably this is because of so much patient advocacy work on patients being like, these are all the things that are different for me, and the criticality of the drugs and the treatment and the timing, right? But I don't know. It's a good question.
I know there was once an app for CF that was to kind of, you need to take these digestive enzymes every time you eat.
Yeah.
And if you don't take the right dosage, you have like constantly abdomen or like stomach aches. So they created an app for that, but nobody used it because it was not co-created with patients. And that's another of my advocacy points, that for every tech you need to work with patients from the start, because what patients learn from a super young age, we have this kind of poo calendar. And so like there are like, if you take not enough medication, your poo looks like this. If you take too much, it looks like this. So you need to check, but you do it from like 2 years old. You used to, so you know it intuitively, almost like with depending on what you eat, how much pills you need to take. And then the physicians came with this fancy app. It was a European consortium of a few million euros, where like a lot of experts worked together on this app. And the idea was that everything you eat, like you had to put in the app, but also the weight, like so many potatoes, so many meat, so many, and I drink this. And then it calculated, a bit like diabetes in the past, it calculated the amount of pills. But it's a huge effort. And if you as a kid, you already do it from 2 years old, you know it intuitively what to do. Nobody felt the need
spending
to start
time like entering into reading. It's like, this actually works. So why are you?
Indeed, some tech
complex. So it's wild. So as a CF patient in Europe, like the communities that you're in, do they kind of cross? Like, is it like global, these patient communities, or is it more centered in?
It's really national, I think, for patients. So typically patients have their national community. But then for data perspective, we have a registry for Europe collecting the data for 55,000 European CF patients. I think that 98% of patients in Europe is part of this registry. So it's a really comprehensive data set of all CF patients in Europe. And in the US and North America, you also have the patient registry for CF, which is also like a huge effort, and a lot of patients are in there. And so we try even to combine the European registry data with the US registry data, the Canada registry, and the Australian registry. So on data, there is like a huge collaboration among those areas.
And those are like often, so patients are saying,
Yeah.
I don't care, like don't worry about my patient privacy, like I want to have my data combined in these bigger registries.
Yes.
Yeah.
Indeed. And what we try to do as a good practice is to really be transparent on what is done with the data. So every time a company or a hospital asks for access to the data, we publish it on the website so patients see where the data are used for. And the contract with the data request organization is also that they publish the outcomes of the research in a peer-reviewed magazine, or at least that they make it transparent, so that there is benefit for the community based on the research that is done on the data.
There have been some discussions in the past about, actually specifically remunerating people, especially people with rare disease, for their data when it's used in research and then in a product that becomes commercialized. Has there been any discussion of that with CS, of, or other rare diseases?
I think it's kind of a sensitive topic.
Especially if you have some multinational one. That'd be very hard to imagine.
And typically for now in Europe, the data mainly come from hospitals. So they don't go direct to patients.
Okay.
But talking to some of the speakers here, the people here as well, they're also working with Rare X in the US with this solid principle, or this patient data vaults in the cloud, where the patient can really store their own data and then provide access to industry or to research organizations. Maybe there could be like a remuneration system. But for now, typically the hospitals are paid for the data. So the hospitals provide the data and the hospitals receive funding, which is kind of okay because they need to do a lot of effort to gather all the data, to put it in the systems. So it's not really that they have profit out of it, but it's more to pay the people who are doing the effort to collect the data. But there is no stream to patients directly in this case.
That's tough. And then RareX, it was a public-private partnership. I think now totally private. Yeah, that's cool. Some of these X's work. Some of them work. So you've got your social media thing. You're interested in AI. What else?
Another topic for me is, of course, access to innovation. The whole, like it was with the Vertex as well. It's a super innovative drug, life-changing drug. But it took like almost 8 years to get reimbursement, for example, in Europe and especially in Belgium.
Oh, wow.
So people were just dying where there was a solution. I was one of those lucky people who was in the trial. So I had kind of early access to innovation, but many patients were really left in the cold. And this is crazy that in this kind of European market where like everything seems so abundant, that still we can't afford to pay for innovative drugs. So this is a huge problem. And I hear the same conversation when it comes to health tech. So we were talking to physicians previous week on those AI solutions, and they were saying, yes, we don't use it because the hospital can't pay for it. We need to pay, for example, €1,000 for 1 year to follow up one patient. Like, where does this budget for these advanced AI tools need to come from? So there are a lot of concerns in affordability, not only for drugs, but also for health tech in the future, because Microsoft, Philips, they're really cool stuff, but they're so expensive. So
it is so expensive, and you can't just build a shit out of it like we can over in the US, right? It's like, oh, we'll just like pump it in, or we'll PM it, or whatever it might be. And
that's what we were talking about. Is like the budgets are dramatically different in the US. Money is just a huge amount more, regardless of anything else. And so, because of that, you just have all of these business models that are optimized for unlimited killing, more or less, like just a money that just keeps increasing. Whereas, obviously, any other country, especially a smaller country, would say, "Well, this is our budget.
Yes,
this is the budget. That's all we have, and then it's done. You can't just keep going, or like it becomes very real. Somebody is trying to access, breakthrough medication or something like that that's priced for something else entirely. I mean, you guys in Europe generally, the prices that you receive from the pharma companies are lower, but they're not zero.
No, they're not zero.
They're not zero,
and they differ indeed between the countries. Because, for example, big countries like Germany and France can afford pay a bit more, and then the company can have lower rates in some East European countries.
You're
to
from
kind
Belgium,
of,
right?
Yes, I'm from Belgium.
And a much smaller country that doesn't have
Yeah,
certainly an unlimited budget or probably as much negotiating.
no, indeed,
Is Germany
no
or France or
negotiating
whatever?
power. Yes,
No.
there are some, like they try to bundle some smaller
Yeah.
countries to do the agreements like
Sure.
together, but
Yeah.
it's not in practice yet. And another concern for small markets is, of course, that health tech companies, like every market in Europe, has a different regulations for bringing health tech to the market.
Yes.
So they do the effort to go to Germany and France because then they, and Belgium, it's only a population of 10 million people, and they have a separate access route for tech. So and they don't even want to do the effort for that. So a lot of things.
Oh, sorry, just calling in
Aline
Aline.
is there.
Aline is here.
Oh my goodness. Yeah. Well, yeah.
Give it just one more second. Give us any parting thoughts,
Give us
Valerie. Yes.
My what? My
Your
birth-
parting, your final words.
My final words,
For the loyal fans of.
I would say if we really want to solve this affordability and access to innovation, then patient voice will be crucial, and involving patients will be crucial to make sure that all the innovations that we pay for are really creating value. So everything that's not creating value out, then we have more financial means for those technologies that bring value. So really advocating for patient voice to be one part of the puzzle and the solution.
Yeah, awesome. Thank you
Okay,
so much.
thank
It was
you,
great
Sarah.
meeting you. Yes. Aline, you ready, birthday girl? Come join us.
Each other?
Yeah. Aline, come over here. We're live. We never stop being live.
Matthew was lost,
Oh,
so
okay.
he may not
All
make
right.
it.
A new guest alert. Getting our picture taken. Yeah, of course. We'll do it all live. Awesome. Thank you so much. Thanks again, Valerie. So you're matching the health colors too. Right. Just so many things. Stuff. So good. So maybe introduce yourself to our experience to one loyal fans.
It is 4 a.m. Eastern time.
We might be awake.
Someone.
European fans.
We
Probably.
We're gonna group them.
We're gonna grow them. Welcome, new fans.
Yeah, okay, so I'm Aline, I'm Digital Health Connector. So that's what I do and how I define myself. So really connecting the different actors in the digital health ecosystem with a focus on startups and doing that like across Europe and in the States. So really believe in innovation coming from the small companies. And my goal in life is push them to the market and to the people who need it, to being patient and healthcare professionals mainly.
Yes, and you live in Barcelona.
Exactly.
And you're involved in the Barcelona health tech scene pretty directly.
Exactly.
And we met a long time ago, but we also got to hang out in Barcelona and go see some of the Innovation Hub people there.
Yes. Looking forward to that.
Yes.
Yes.
And we are
coming to Barcelona.
we're gonna be
We're
there
going to the Health
in
Tech
December.
Forward
Health Tech Forward will be there.
Yeah.
That's
It's gonna be
exciting.
growing ecosystem.
Yeah.
And I love it.
Yeah.
Yeah. Lots of things happening there.
We already know we're gonna love it. It's gonna be great.
We're already
It's gonna
gonna,
be
I mean, I already love it.
How did you get into this?
It was actually by chance.
Same.
In healthcare, you mean, right?
Yeah.
So
Digital health connector, like
I think it's something that I have in me. I see it as a gift, connecting people and the healthcare. I was actually in my business school. There was an event where startups were coming to meet MBAs for the summer. And I was looking in French with my friends from class, and someone came and said, "Hey, she speaks French." And that startups was looking for someone to explore the French market. Absolutely random, but I think I fell in love with healthcare, and that's 14 years.
well, that's fantastic. Well, that's really cool. So what area within digital health are you super excited about?
Startups. That's really my
Just startups.
area.
Is there a specific?
Any particular
Are you interested in
subsegments?
AI?
Not so much.
Yeah.
I'm into like women's
That's
health,
right.
microbiome, DNA, personalized medicine. Yeah.
There's at least the few conferences that I have attended in Europe, the microbiome thing is like big. Here in the US, it's like that's not real.
Well,
Not
there were some
real.
startups that didn't do so well.
We had a couple scandals.
we have more things in the US than in Europe. We don't have really many players in Europe. I think we're looking more at what's happening in the US. I did the test. There was companies from the US.
Yeah.
Oh yeah,
Yeah,
what was the one? Oh hey,
You got
what's the
some-
scandal? You biome?
And actually they I think the founders of Ubiome escaped to Germany.
To Germany, yeah, exactly.
Yeah, it was like
Come on, extend the show.
come on in,
Yeah,
come on in, gals.
Stay here.
We-
This is
We're
slow down.
waiting. Listen, guys. Again, if Melissa were here, we would have much more organization, but we are not. Yeah, the Ubiome founders escaped to Germany, I want to say, and I think one of them was a German citizen, and like
They were just married.
yeah, they escaped to Berlin somewhere. They're hiding somewhere in Berlin, as far as I know.
We're not.
If you are the Ubiome founders and you want to come on our show and speak,
We'll
we're
be
here.
all day.
We'll come to Berlin.
Probably.
Absolutely.
Also,
Well,
if you pay for
right?
it, we will definitely come.
I don't know if they can access their money. Might be locked
Okay.
up in
So,
the courts.
what is women's health to you?
So women's health, it's not. I like the part that we don't really talk about so much. So not really periods or fertility, but more like health, mental health linked to the woman.
Yeah.
I've been actually, I wear the Oura ring.
Yeah.
And I've been using that. I learned so much about like my women's health through that.
Nice.
How
I have a
my
lot of
life
people
is
say that.
impacted.
People really like that.
It's
Yeah.
amazing.
Yeah. It's awesome.
Yeah.
And you're a health ambassador. Did I make that up? Are you what?
Yeah.
Okay.
Yeah, exactly.
So what
What does that mean?
talk to us about health, the conference in Europe. Like what are we looking forward to? What do we think about health joining the European health tech scene?
But
Tell us
I
more.
think it was a big event. Because,
Okay.
I mean, I've been to the one in the US and following for like since the beginning.
Like Disney World.
And exactly. So finally, it was coming here, and we're very excited to have it here. I think it's like they did a great job. Like it's very appealing on the different stages, the same concept than in the US. So like there's about on women's health actually, a brief about patients.
Yeah.
I think all the different actors are really represented, and it's great to bring the different actors of the ecosystem here for those just for this.
Yeah.
Nice. Yeah.
Very cool.
Yeah.
Into it.
Any big announcements? We were invited to a Philips announcement in a little bit. That's all we know about so far. Anything else?
Allegedly, they asked for us
Allegedly.
specifically.
Because we're so
They made
famous.
this for everybody.
They may have asked for everyone. I don't know. And we're gonna go with that. We're real media. We are not real media.
You're gonna share it live.
No, we're not going to broadcast it unless they want us to. Unless they want to have a special edition of the. We're not really very. Nor do we have any tech. You know.
We didn't. Community manager who usually does everything. So yeah, she's back in New Jersey. So
This is a bit of a preview. You know, we'll be hopefully getting to work with you and see you in Barcelona for Health Tech Forward.
it's gonna be awesome.
We're gonna want to interview, folks from Barcelona who are doing really interesting things in either Catalan or in the Spanish market. So hoping that those folks will be there and we can have some good conversations.
Yeah,
that'll be good.
It's gonna be awesome.
Cool. Yeah.
Well,
Any words for our loyal 0 to 1 fans and new fans, maybe?
Well, I hope that you enjoy the few days here, that you're going to learn a lot from the European health ecosystem, because I understand that right now your followers are more US, but they're going to become more European.
most likely.
Yeah.
They
Yes,
can see
global.
what's happening in
That's the
Europe.
goal.
Get excited about it.
Awesome.
Yeah.
Thank you so much.
Thank you. Thanks a lot. Today. It was great.
Okay, I'll scoot. Here we go.
All right, so we had,
All right.
this location is a little bit difficult to find. So we have completely lost one of our guests. Solomay made it.
Repeat, yes. Yes.
Also, a person who is seemingly everywhere.
Seemingly everywhere. We're playing a lot of.
So let's go on. So introduce yourself again to our loyal followers who may or may not be European today. We're not.
Oh, yes. How do I beat Barcelona? How amazing. Hi, everyone.
I mean, we like Amsterdam. We like Amsterdam.
Oh,
Barcelona's pretty
yeah.
great.
Amsterdam, yeah.
So let's introduce yourself. Tell us the whole story.
Oh gosh, wow. Hi, I'm Solomay Tibaboo, and I'm the founder of Behavioral Health Tech. So excited to be here at Health Europe. So much fun, and nice to see old and new faces.
Yeah.
Here we are.
Wait, so why are you here?
Just to explore, hang out.
Check it out.
Yeah.
Same. Same. We're here. Well, we're here to increase our global audience.
Increase our global
This is a good goal. And we also have my colleague who is visiting. That was half of it. Danielle hadn't been out of the country, so we needed a. This is Danielle. This is
Danielle is amazing.
she is the only reason we are organized at anything. So yes,
we are missing the reason why we are organized at anything, and it goes.
So to be fair, like we tried to bring Melissa, she just for other reasons was unable to attend this time. But
She's coming to Barcelona.
Are you going to go to Barcelona?
Yeah.
I was listening. I should
Check forward.
I was in Poland. And now so we're going. Everybody's going.
It's so sad to miss that. My Polish roots. I'm 50%
right.
Polish.
I know. Well, it's fun.
It's fun. It's still amazing.
I should go.
It's still
You
great
should
to visit.
definitely go. Are you speaking? Do you do?
No, it's chilling. We're having fun.
Are you seeing? Are you? I mean, you're in all. I should have had you speak. And are you seeing? Have you met any interesting behavioral health tech companies? Or what's the situation here?
Few actually. We had a nice little hangout downstairs. There's
Nice.
maternal mental health.
Because you said we need a selfie.
Oh,
You keep going. Keep going.
Okay.
But with the right hand, because I always have the big head in the selfies. Okay. Yes.
Oh,
All right.
live
Look left.
I know something about that. I didn't. I'm too old to know that there's like a light.
You gotta look
You gotta look at the light.
otherwise- Right.
You guys. Amazing. Okay, another one.
Sorority arm. What do we do?
Just do this. All right.
So yes. So this is the first year of Health Europe.
Yes. Amazing.
It's I think you're like doing a good job, right?
Astounding. I mean, after experiencing what goes into planning a conference, I just
Lisa
can't
was
even-
just saying
I was the same.
this is
Conferences are so
what was I thinking? I think.
hard. Yeah, you just really, you're like, okay.
and now you're doing it again. Now it's like your thing. Yes. We're going right. We're going. I'm going to Solome's conference.
Yeah.
Behavioral health.
We go everywhere and we talk to people. So start thinking about we should talk to.
We're gonna throw a party.
With startups, with companies, with people. Yeah.
Yeah, well, Lisa, people don't often know that we do not, in fact, work at the same company. But yes,
We do not work at the same company.
but
we are.
yes, it is true. Lisa often, it's the same thing. But yeah, we are throwing a party at
Yes,
Solome's
yes,
conference.
Amazing.
Speaking of other conferences, so it's gonna be
Behavioral Health Tech November in Scottsdale.
yeah, at that
Phoenix?
beautiful Bill.
Yes.
Something. It was lovely last year. So
Great.
Okay, so what kind of sessions you going to here?
Yeah, I really enjoyed the one with Commonwealth Fund and Health Tech for Medicaid. Those
The one that just happened. We
Really
got
great
great about
series.
it. The health
Oh.
equity one.
so great. So yeah, it's nice
What was
to
the takeaways?
seeing how the different entities in the different countries can actually. Somebody had asked a good question about. I mean, it was hard hitting. How are you guys actually collaborating, and do you need some convener to be able to do it? And very fun. I thought that was a nice little layup for Commonwealth Fund because they do such a good job of convening stakeholders to advance policy and health equity and behavioral health. Well, there's a lot of behavioral
Yeah.
health, so that was fun.
Yeah.
Yeah, I mean the EU itself, like the EU generally, they have frameworks, they have things like that, and they have a layer of governance. But it's very hard to. They can actually specifically tell each country what to do,
Yep.
how to work, and they all have their own governments, their own systems of regulation, legislation. So it's not convening is still hard.
Yeah.
Regardless, I
Yeah.
mean it's the same thing, right? We have the same problems. You still need somebody to come together and say like, okay, what if you change this or change this so we could work together more? And Valerie was just telling us how hard it is for the smaller countries in the EU to have any kind of negotiating power or any kind of anything compared to bigger countries. So that's
Yeah, the
tough.
whole like different country thing is rough.
Yes,
Yeah.
as it is.
Yeah.
Just like our states.
Yeah, but our states are easier also.
I don't know about that.
Like we don't have to
Sometimes.
get like, different clearance for each
Oh.
state.
Depends.
Depends.
What are we talking about?
It does well,
Depends.
depends.
They will be in different states. And
My
I-
uterus is treated differently in multiple
That's true.
states.
Yeah,
Right.
yeah.
That
It is
that's
different. It is different.
unfortunate.
It's getting worse.
Yeah,
It's getting worse.
we got our friends in Canada. Seem like they're pretty down.
Yeah, I feel like they're just trying to keep the tiger.
People think I'm from Canada. It's my Fargo accent.
Yeah, a little Canadian lilt.
Is that what it's
It's
called?
a Canadian lilt.
I
Yeah,
haven't even
lilt.
lived there in like 15 years.
You did.
I think,
And it was influential for you, clearly.
Clearly.
I think we have a little bit of politics.
A little bit of
Do you go to a bunch of, what do you think about AI and behavioral health?
So much opportunity.
Is there?
Absolutely.
What do you think?
I mean, from anything from having the ability to evaluate if there's some suicide ideation in patients
Like
long
triage.
before
Yeah.
triage is a whole other thing. In fact, connected to evaluating providers and their ability to follow measurement-based care, evidence-based practices. There's a lot of opportunity for AI.
Yeah.
involved.
Yeah, it's like a really interesting thing. It's actually Canadian. I was evaluating it as an angel investment, and the bummer was because it's like single payer system up there. It made sense what they were trying to do. They were like, so
different.
get people in faster, and we won't bill for high intensity services. And you have to be like, whoa, whoa, whoa,
Intensity services. We are gonna bill.
It was using it basically like different voice notes from patients. So it's super interesting, but yeah, I'm a little stressed out about it.
We're at the beginning of that
We're at
space.
the beginning.
Yes.
Yeah.
I need to be drinking the Kool-Aid, but really, there's a lot of opportunity.
Yeah,
Definitely. What are we, should we do a little preview of behavioral health in November? Like, what are we going to expect to see? What should people, why would anyone want to attend, for example, besides just like the weather's really nice in November in Phoenix?
Yes, at the very least.
At
You
the
can
very
expect
least.
that. Yeah, I'm excited to convene all the stakeholders, behavioral health stakeholders, providers, payers, startups, investors, policymakers, pharma. And what's really exciting this year is Kat has helped us curate some amazing content.
Basically,
Amazing.
Just really thrilled to continue having the policy lens.
Yeah.
And
So,
engaging
Mr.
people,
Tom,
like,
friend of the show, will be. Well, you have awesome tracks and sessions, and then all we did is helped get some feds to talk about the behavioral health IT thing and the new SMD letter.
So excited.
Or show letters.
I think it's a show letter.
Yeah.
And also yesterday, now we're just doing U.S. news. Sorry. The IBH, the Innovations in Behavioral Health model, the NOFO, the Notice of Funding was released.
Big deal.
And that will be a big deal. And I certainly hope that other states and countries will take notice because it is a whole system plan, right? It's a global budgeting.
Care. Yeah, very exciting stuff.
I love all the models that are in the states.
Yeah.
I love the states.
Yeah. That's a big deal. It was released yesterday.
Exactly.
So we have Ann Zink, Umair Shah, and then Darshak's going to talk about the public health thing. We're going to do the state thing, and then we have a tribal session.
So exciting.
Yeah.
I really thank you so much. Kat knows everybody and she brings the best people together. So I'm very, very
We're going to have
So at the very least, weather, party, you can count on that.
A lot of good stuff.
Okay, we have had an interesting non-scheduled show.
Non-scheduled show. We got a new final guest. Any final words for?
No, thank you. Thanks for having me. Hashtag Health Europe. Thank you so much for having me. Right, let me switch.
She's gonna switch. Okay, final unscheduled guest. We think.
We've got
Who is coming?
We've 5 minutos and
Cinco minutos, and we gotta go.
I think we could.
No,
We are live.
Oh, right now. We have to do this live.
So we just talked about your panel. Apparently, it was great.
Okay.
Yeah, awesome.
Recording.
All things.
How was it?
Yes. You know, it was an acknowledgement of the fact that we have not gotten very far. And a
Also,
very
this is Alamika.
hi.
Forgot to introduce her.
And I think for this audience, one thing I'd like to explain is, you know, people are like, well, Medicaid is not anywhere else but the U.S. Why is this a issue, right? But if you think about it, it's as close as we're ever going to get in the U.S. in my lifetime, I believe, to a single payer system. It's kind of a birth to death. Probably a little sicker population than just a total generalizable population, just by the nature of having, you know, eligibility. Of eligibility, but also like the massive disinvestment in many of our populations that are disabled or genetically unlucky, right? But I think then it is in some ways generalizable to a system across the globe, and it's the most challenging system that many of the single payer systems around the country, around the world, are thinking about.
Yeah.
So I think that there is some nexus there on how we could do a better job, but it still shocks me how we're not thinking about humanity, or we're not thinking about people.
Right. Right.
It's always like, oh, we have a new structure that we're focusing on, or
system in place.
yeah, we're calling something X, but it's not addressing the fact that in many general, like in many first world nations, our life expectancy is going down, or going up, excuse me, and our ability, we're dying from more things, and we're dying younger, and it's a wealth problem more than it is a poverty tax, right? So what I mean by that is the more money we spend on healthcare, the worse our outcomes become. That is a strange.
Doesn't make sense.
Yeah, and I don't think.
I mean, some of it is, again, like you said, because people are living longer and they have more time to develop diseases that we have more and more advanced, expensive, modalities of care. But then there's also this entire part of the population that's just getting worse and worse and worse in terms of health and life.
Yeah. And those are the things, when you stratify the data, that are problematic. It's not that people are living longer and that's why it's costing us more money. I think that's the line they like to tell us. It's not palliative care that's, exacerbating the system.
They're like, well, people stop smoking, which was good, but then they live longer, which is bad. And you're like, no, that's not quite.
But the reality is, if you can't have a child in the U.S. effectively as a Indigenous or Black woman, those outcomes are like significantly worse than they were when my grandmother, who couldn't have children in hospitals, right? Birth outcomes are worse. And my grandfather, who would have been 95, was actually born in charity because the Catholics believed in, reporting all births, I guess, in New Orleans back in the day. But that's a rare occurrence. But if you look at infant mortality, even in hospitals, it is way worse today than it was then. That just says something for our lack of community engagement, our lack of listening to what people need and what they're prioritizing.
So just like, what a massive failure, right? Like, what a
it's a
colossal failure.
Yeah, and some of these are self-induced challenges. Like, the opioid epidemic is not something that we had to deal with necessarily 50 years ago, right?
Right.
But it's exacerbated by a whole host of other issues. Because I think if you don't have jobs in your community, and you don't have the ability to, indicate what we believe value is for folks, and we've lost our connection to institutions, whatever that means. I know that's fancy over there.
I think it still works. It's fine.
Yeah. Oh, mics are great.
Okay. You want to switch?
No.
We're good.
Well, we did have 3, but only 2 sync. We're used to it. This is how it normally goes. Sometimes we have no mics.
And then there's that.
Yeah. Okay. So, Kamika, we got to go to this Phillips thing.
Yes.
Allegedly, we were personally invited, which may or may not be true. We're not sure. But one big takeaway for our European audience, from your perspective, as someone who's a big advocate for Medicaid and underserved populations.
Underlooked populations and underserved communities. Biggest takeaway is we need to collaborate.
Yeah.
We really need to stop thinking that we have to have more public-private partnerships. They have to look very different than things we've done before. We have to be willing to take risks.
Yeah.
I think that the cost is greater than our ability to outsmart the problem. We're past all the cheap solutions in the beginning.
Right. And I mean, just to add on to that, I would say that, like you just said, the kinds of challenges that U.S. state Medicaid programs face are for sure the same ones that a smaller country in Europe or in anywhere else will face in terms of budgeting, in terms of how to serve underserved populations, all of those things, right?
Yeah, I mean, I actually think in many cases we could learn a lot from, Europe, because there are nexuses of community. We are losing nexuses of community. Yeah. You just go around the corner and you see, schools, parks, cafes, like you see economic nexuses, and we have lost that in our kind of big box thinking, and, large capitalistic swings. So, but as you guys are going to Phillips,
we'll see what happens.
We'll see what they say.
We'll see what happens.
See what they say.
I think a big old survey or something.
So possibly, yes. Well, shout out to Health Europe for having all of us.
Yes.
way.
Hi, Health Europe. Thank you.
And,
Nice,
we'll see
nice
what
to have so many people here in one room. We'll see what happens. I would like to see a market difference, not just having more people at the conference, but actually seeing more collaborations, more co-conspiring.
Nice.
Yeah. Real things happening. More real things happening. More lives being saved. In the next year.
Awesome.
Right.
Thank you,
Adamika. Oh my gosh, thanks for making it because we know you like ran from your panel.
Oh my
You're like,
goodness.
I did, and then I was upstairs on the other side, so I also got lots of steps in. Thank you.
Well,
Yeah.
here,
All right,
take a
one
selfie.
more
Hold
live
on.
selfie. All right. So
No air.
there's no
No, I
air.
know.
So to our loyal followers, we will maybe be back later today. See you later.